the United Kingdom, working in the NHS. And as you all know that I was a consultant gynecologist there, and when you're in the process, the part of your job is to train, to teach. And we did a lot of work for junior doctors and also medical students. And my best memory is when I was teaching the medical students in Birmingham University, Birmingham Medical School. So then I have moved here in Abu Dhabi, and I'm a consultant gynecologist in College Hospital, and currently I'm also a professor in Khalifa University in Abu Dhabi. So thank you very much to all those who have joined. Good morning, good afternoon, good evening to everyone, whoever is where they are. My topic today is normal and abnormal labor. We're going to do that, and then after a short break, as I said, we'll do a little talk on CTG. My aim in the whole lecture is to hopefully demystify obstetrics and gynecology for you. And I absolutely understand that for medical students, sometimes it's a bit overwhelming, obstetrics and gynecology, especially with so many abbreviations and acronyms and things that we have in ONG. So hopefully my aim is to make it simple for you. It's very interactive. You can ask your questions. We can go through it again at the end, and we take it from there. So the learning objectives we'll talk about normal labor, abnormal labor, what is lie, presentation, position, and then of course the CTG. Now, coming to definitions, I chose the WHO definition before because everybody's coming from different parts. So how the WHO defines normal labor is the birth which is spontaneous in onset and low risk, and also whether and remains low risk throughout labor and delivery. And the baby is born spontaneously in the vertex position between 37 and 42 weeks of pregnancy. So as you can see in the underlined areas, there are lots of caveats to a normal labor. That's all that has to be for us to define it, that labor is going smoothly. And if you look at the other definition that we also use is that labor is as the presence of regular, painful uterine contractions with progressive cervical dilatation and effacement. And that's what we are going to try to understand. What is the difference between effacement and dilatation? Now, labor is usually defined into 3 stages. Okay, so the first stage of labor, when labor actually starts, is when the cervix opens from 0, because the cervix is not open when you're not in labor, and then goes up to 10 centimeters. So the first stage, always try to define it, because you will be asked in your MCQs and things to define labor. So the first thing that you would define it is that the first stage of labor is from the 0 dilatation to 10 centimeters of cervical dilatation. The second stage of labor is from 10 centimeters of dilatation to the delivery of the baby. And the third stage of labor is from the delivery of the baby to the delivery of the placenta. Okay, so from to in all the 3 stages. Now, to add to it, always remember the first stage of labor, which is from 0 dilatation to full dilatation, which is 10 centimeters, has got 2 phases. So there's a latent phase, or some also call it the passive phase. And what that means is that you will find that this is the let's say the slower phase, and there are some variable changes to the cervix with some degree of effacement and progression up to 5 centimeters. So any cervical dilatation less than 5 centimeters would be considered as the passive phase of the first stage of labor. And as soon as you go more than 5 centimeters, that would be the active phase. And the changes that we are talking about in the cervix are the various changes that happen in the hyaluronic acid and all the physiological changes that makes the cervix change, soften, be taken up and dilated. And when the active phase starts, which is from the 5 centimeters, then the contractions become more regular, more painful, and lead to more rapid dilatation from 5 centimeters to 10 centimeters, which is then, as you now know, is the second stage of labor. I've put some diagrams also to explain to you again the enigma of effacement and dilatation. So you see, in a cervix, when you see this is the uterus, the fundus, the body of the uterus, the tubes coming out of it, and the cervix itself here is a 2.5 centimeter long structure, which then leads into the uterus.
Sadia can't see the picture. Did you put a picture? There's no picture.
No, it'll come next. So, so that is the total length. This length, when is taken up, that means either you would use the word taken up or you would use the word gets shorter. It is called effacement. And then the dilatation starts. Now, over here, you can see what I was demonstrating in that model. This is the total length of the cervix. And over here, you can see it says 0% effaced, which means this patient is not in labor and the cervix is there in its full length. And then you move on to say, oh, from about a 3 centimeter cervix, it is now left with only 1.5 centimeters. So it is 50% effaced or taken up. And after it is 100% effaced, that means there is now no cervix. You can also say that because the whole cervix is now taken up as part of the uterus. And guess what is happening now? Yes, the cervix is now dilating. So can you see that over here you can say that there is 1 centimeter dilatation. And as this picture will show you, from 1 to 3 to 4 to 5 to finally its full dilatation, which is 10 centimeters. So this is how you would define effacement and dilatation. Again, in this picture also, this is not effaced because it has got the full length of the cervix here. And this is effaced. See how thin it becomes and how more and more it becomes taken up or part of the uterus. And over here, when you will see, where is the cervix? There isn't any because the whole cervix has been taken up and fully dilated to 10 centimeters to allow the baby's head to come down. So what about the duration of labor? Now, there was this very sad man in history, his name was Friedman, and he spent like all his life trying to calculate and tell us about the rate of dilatation of the cervix. And he found out that what we would tell you now, that the minimum possible rate that we will say is okay for a woman to go through labor is 0.5 centimeter per hour. And we would give that to somebody who hasn't had a baby before. And by now, I'm sure you would know that that word is nulliparous. That means a woman who hasn't delivered before and she's going through her first labor, we would tell her that, okay, she would need at least 0.5 centimeter per hour to go through labor. Sometimes people take longer or shorter, but this would be as a definition and as an answer to a question, we can say that. Okay. Now, these graphs look very complicated when you look at them, but I will just slowly take you through them, okay? If you see the two axes over here, this is the time, and this is the dilatation of the cervix. As we discussed, there is a latent phase of the first stage of labor, which is kind of slow. So this patient was not in labor. She was 0 centimeters dilated. And slowly over time, in 2 hours, 4 hours, 6 hours, 8 hours, you can see that she's slowly dilating from 2 to 4, reaches a bit of accelerative phase of labor, 8, and then 10. So In 14 hours, she has reached the maximum, which is 10 centimeters. So that's what this graph depicts. Time with dilatation. We've got another line over here. So what is that depicting? If you would see on this side, there are certain numbers which say +1, +2, +3, +4. So if you can imagine that, this is actually the pelvis, okay, and the baby's head is coming from the inlet of the pelvis, descending right down to come out of the mama, that would be your +4 to come out. So as the cervix dilates, the labor, the strength of the contractions gets the head to come down and descend. So you will often be given these graphs for your MCQs and questions to explain these graphs. So I hope that that is now clear. So this is the total length of the labor leading to 10 centimeter dilatation, and this is marked against the time, and in this time the head is also coming down. Okay, so what is abnormal labor then? Everything is not going according to plan. So we said that it has to be spontaneous, it has to be, for labor to be normal, we said it had to be spontaneous, it has to be low risk, and that the baby should be born on its own, decide when it wants to come and comes, has to be head down, and has to be between 37 and 42 weeks. Well, if all of that doesn't happen, then we will call it an abnormal labor. So the labor didn't start on its own, it was induced. The patient wasn't low risk, she was a high risk patient. So diabetes, blood pressure, any other obesity, epilepsy, all of these problems were in this woman. So she wasn't a low risk labor, she was a high risk labor. And then it didn't come out on its own. We had to use a forceps or 1-2s to help it deliver. That will make it into abnormal labor. And it was not the head down. So we'll bring in our little Bob the baby. It's supposed to deliver like this, but it didn't deliver like this. And it was everything else coming, an arm and a leg or a hip or a bottom, but not the vertex. And the labor started before 37 weeks or even after 42 weeks, it was not starting. Okay, so these are, when all of these things go wrong, that is abnormal labor. Now we will talk about another difficult word that people keep using, the dystocia of labor. Why was the labor prolonged, and what is? So we gave a definition. We said, okay, you've got half a centimeter per hour to go from 0 to 10, and that is allowed. But then you will see that that is not happening. You're giving them hours and hours, and the labor is not progressing. So it is actually stalling or stopping. And the cervix is not dilating. And the baby's head is not coming down as per the graph ordered. So that is what is called dystocia of labor, when things are not going according to plan. So again, I'll come back to this graph. We said, okay, the slow phase is the latent phase. And we are saying that it is coming down from 0 to 8 centimeters and should dilate and become 10 centimeters at some point, but that didn't happen. So what are we going to do? Now, let's look at this graph, another graph, but we'll go through it slowly so you will be able to decipher it. I just want you to concentrate on this line at the moment, okay? The first lady in room 1, shall we say, now you're in a virtual labor ward. She comes in at 3 centimeters, okay? And immediately within 4 hours, guess what? She's 7 centimeters. And then around 8 hours or so, she's almost 8 centimeters. And bless her, within 9-10 hours, she's fully dilated, ready to go to the third stage of labor, which is from the full dilatation to the delivery of the baby. So how cool is that? Okay, she had no problems. She just came at uh, 12 o'clock in the midnight, and within 10 o'clock in the morning, she is delivered. Now, what's happening in room 1? She came, she wasn't in labor, and then after about 7 hours, she's 3 centimeters. In 10 hours, she's again 3 centimeters. Then we as obstetricians and gynecologists, we do things to them, and we will discuss that later, which helps them and somehow drag her to 10 centimeters in about 14 hours. She wasn't as lucky as this lady who came and was fully dilated within 9 hours. What's happening in room 3? She also came at 1 o'clock. She also came at 1 centimeter dilatation. And after 12 hours, bless her, she hasn't even reached 3 centimeters. And then after hours and hours and hours, more than 20 hours, she's now 10 centimeters. So you can see that these are 3 different women going through 3 different types of labor. But they do end up in full dilatation, which is 10 centimeters. So this graph is showing, the last graph and the second graph is showing primary dysfunctional labor. So you will be asked this question and you will be given these graphs to explain, and just, it's very, very simple. All of them reach 10 centimeters, but there is delay in progress in different patients. And as you can see that half a centimeter didn't happen, but they finally reached full dilatation. So this kind of graph is showing that this is primary dysfunctional labor. Then if you look at this graph, first what happened here? So somebody came at 1 centimeter. After 7 hours, they were 7 centimeters. And then they remained 7 centimeters for another 2 hours. Another 2 hours, they are okay, 9 centimeters. See, they never reached 10 centimeters. So you will have different types of graphs given to you in which there is progress, but there is some kind of arrest, stalling of the labor, where the line never reaches 10 centimeters. That will be your clue to say that this is secondary arrest of labor. So this is the difference between primary dysfunctional labor and secondary arrest. These 2 graphs are showing to you. If anybody wants to ask a question, we can always stop and explain things again. Otherwise, I'll just carry on. So primary dysfunction.
Somebody asked, and I'm actually answering in the chat box. So somebody asked in the chat box, can dilatation and effacement occur at the same time? So I said, no, the cervix has to shorten first before it opens.
Yes. So, so now we have to talk about why did that happen? So why were these 2 ladies a bit unlucky in taking so long to get to A to B, from A to B, and this lady never ever progressed to full dilatation? Why was that? So if you look at all the causes of abnormal labor, to make it simple for you guys, to make like an aid memoir, we use the 5 P's: the power, the passage, the passenger, the psyche, and the persons. So these are all the causes which can happen and which you have to diagnose as to which one is fitting all these different ladies and why is that happening. So this is a nice slide also to tell you the meaning of why we put all these P's. So the first P tells you about the power. Power means the strength of the contractions and the ability of a mother to push a baby, how much power she has when in the second stage of labor to actually push out a baby to reach the third stage of labor. Then the passenger. And who's the passenger?
You define.
So we want to know that what is the size of the baby, which is the position of the baby, which is not allowing this passenger to travel the pelvis. And then the passage, the shape of the mother's pelvis, and the psyche of the mother. What is her state of mind? Is she fearful of labor? Has she got the confidence given to her, have you prepared her in the 9 months to say, yes, you can do it? And of course, the team that is looking after her, the competent and supportive team which is around her. And believe me, if you remove one of this, then it's very rare that you would have a successful outcome of labor. So let's look at this in some detail. As we discussed, when we say power, it means the uterine contractions, how powerfully and how much contractions you have, which is going to lead to the effacement and dilatation. And then once you reach the second stage of labor, how much power the woman has in terms of giving her that effort to push the baby out. So that's the power. When it comes to the passage, anybody wants to answer what am I talking about when it comes to passage? I can hear only my voice. Let's hear from somebody else. Anybody wants to volunteer?
Is that basically like the route the baby has to travel through the pelvis or through the birth canal?
Yes, so we are talking about the birth canal, right? Good. So birth canal consists of which part? There is the bony part. Okay, the baby has to traverse the bony part. So what can go wrong with the bony part? If you think about from the European setting, the highest cause of death in young individuals is what? Road traffic accidents, right? So if somebody survived a road traffic accident, they can get shearing injuries in their bony passage. So it's not as best for it to allow the baby to come through. Then you have got conditions like osteomalacia, which make the pelvis very soft. And this is more from the resource poor countries that unfortunately because of deficiency of vitamin D, and that would happen. So there are lots of problems that can be wrong with the bony passage, which is not allowing the passenger to travel through. And then there is the soft passage. The soft passage consists of cartilages and of course the subcutaneous tissue and all the other organs that are in the passage. So your uterus can have a large fibroid in it, the cervix can have a fibroid, there can be a big tumor on the ovary. Just fill in the passage with whatever things that are normally there, and they have got some abnormality on them, which would give problems to the passage. Why I mentioned subcutaneous tissue is what is unfortunately associated with obesity. So the bones are okay, but if you will have an obese lady, then her passage will become smaller and wouldn't allow the baby to pass through. And the baby, of course, is our passenger. Passenger can simply be the size of the baby is too large, or the position of the baby. Now we'll go through each and every one of this slowly so you can understand along with some photographs. So we are going to talk about the lie, the attitude, the presentations, and lots of different positions, right? And any of these which would not be normal would not allow the passenger to go through as quickly as we want, and that will lead to abnormal labor. So let's talk about the lie. What is the lie of what do you mean by fetal lie? Fetal lie means, if you look at the definition, the relationship between the long axis of the fetus, okay, with respect to the long axis of the mother. And the possibilities are longitudinal, transverse, and can be oblique. Let me show you on this. Okay, so we are talking about, what did we say? Relationship between the long axis of the fetus with respect to the long axis of the mother. So this is the long axis of the mother, right? And this is the long axis of the fetus. And can you see that they are in perfect harmony. So we are going to call this a longitudinal lie with a cephalic presentation or a vertex presentation. Okay. Over here, we have the same thing. We have a beautiful harmony between the longitudinal lie of the fetus and the longitudinal lie of the mother. The only thing is that we have got a breech presentation. So the vertex or the cephalic presentation is on the top, and there is a breech presentation. So we call this abnormal because it can give problems during labor, but a very expert and helpful team can help to deliver a breech baby as long as the lie is longitudinal. But what's going on here? So this is the longitudinal axis of the mother, and this is the longitudinal axis of the baby. And you can see that they are not in harmony, and the baby is lying transverse. So that's why this lie will be called as transverse lie, with the head or the cephalic or the head lying in the mother's left hand side. So always you will call you will name the position according to the mother. The mother will be the denominator to tell us which side the head is. Okay, so that is your fetal lie.
Dr. Sadia, we just have one question here. Someone asked, so is it impossible to have no effacement but full dilatation, so 10 centimeters dilatation?
Okay, so I know that this is this confuses people a lot. Let me quickly go back to that, and then I'll take the question again. Okay. Yeah. Okay. So what was the question?
Okay, there's another question as well after it. So what first question is, so is it impossible to have no effacement but full dilatation? And then the second question is the secondary arrest chart with 9 centimeters dilatation. The difference between 9 and 10 centimeters is clearly visible. So is 9 centimeters enough to deliver?
No, never. So you can only deliver at full dilatation, which is 10 centimeters. So if you have 9 centimeters, you cannot deliver that baby vaginally. Okay, just be very clear in that. There is a 1 centimeter difference, but that difference is life and death for the mother. If you are going to force a baby to come through 9 centimeters, that cervix is going to rip in your cervical artery and then your uterine artery, and you'll have a massive tear in that uterus. So you have to be confident to know that 1 centimeter difference. If it is full dilatation, only then you can have a vaginal delivery. Otherwise, you will have to deliver the baby by cesarean section.
Sadia, can I just give an example here? I think just make it simple. Kids, if you consider a balloon, okay, a balloon, you basically blow the balloon. So when you start blowing, you just see the lower part is like it's elongated, okay, and the balloon is blowing. So it's exactly the same. The cervix, which has to open it completely to become part of the uterus, and only then, you know, it can open up. Similarly, when balloon fully opens, the point from which you blow the balloon is no more, you know, it's no more extended. So it's exactly the same thing happens with the uterus.
Like you can say, when the cervix is fully effaced, there is actually no cervix because it has been fully taken up by the uterus. So all you are going to be left up with a big hole, and that hole is 10 centimeter dilated cervix. And even if the cervix is 5 centimeters dilated, it still can be either partially effaced, which you can see over here. See, you can still see a cervix here, and the dilatation in this photo is 1 centimeter. But this could be 5 centimeters. So you can have half a dilatation and half of an effacement. So that can happen, right? But to have full dilatation, you need to get rid of the cervix. That's what is called cervix. No cervix at all. So I think that is where the confusion was.
Sadia, there's a question. How do you measure? So just explain with the fingers, you know, the dilatation.
So we spend our whole life measuring our fingers and knowing what is 10 centimeters between our fingers. So this is one of the like, shall we say, experience that we would know. But for young learners, we have got many models, okay? So you can put your own fingers through the model to actually know. So this will be 1 centimeter. And if the finger takes 2 centimeters, 3 centimeters, you need to know it on the ruler. You'll be surprised how many people, when we ask them on the ruler just to mark from point A to point B, how many centimeters is that? You will be surprised at the difference between your 10 centimeters and my 10 centimeters. So first of all, you know it on the ruler, and then you will know it exactly on the cervix. The cervix begins like this. You feel the nose, there's no dilatation, nothing, and the feeling is also like the nose. And slowly there's an opening, and the 1 finger can go in, 2 fingers, 3 fingers, 4 fingers, and then we would need to measure it like that, and that's 10 centimeters for me, right? Okay, so so we talked about the passage, we talked about the passenger, so we were talking about the lie. Okay, I hope that's clear. And then comes the attitude, is to how a baby actually sits inside the uterus. So it says that the fetal attitude describes the position of the baby's body. So the normal fetal attitude is commonly called the fetal position, with the head tucked down to the chest, and the arms and legs are drawn in towards the center of the chest. A very famous fetal position. I'm sure you have heard it in the normal conversation also. So that's your perfect fetus, okay? This is a good baby. It's coming down with its head first, and look at the attitude of the baby as we describe. Its head is tucked down to the chest. Its arms and legs are drawn in towards the center of the chest, and it is like a perfect fetal position. Then start the naughty babies. Okay, the head is not as tucked in, so we call it, it's a bit extended. So, or you can say that the flexion is not complete. This one is very bad flexion and moving into extending the head. And when a baby does a full extension, guess what is coming out of the pelvic outlet? It's the face, which is the face presentation, which is an abnormal presentation. So you can have a cephalic presentation, which is the perfect complete flexion presentation. You can have the moderate flexion or the military presentation, or you can have the half extended head where the brow comes. And this increases the diameter of the baby in such a way that this baby cannot be delivered vaginally. And then if the baby fully extends its head, then that would be called a face presentation. Okay. So when we talk about presentation, we want a definition. We say that the presentation of a fetus about to be born specifies which anatomical part of the fetus is leading. That is, which part is closest to the inlet of the pelvis as it goes into the birth canal. And then, according to the leading part, we will identify it. So the normal is cephalic or vertex. And if it is not the head and it is any other part presenting, then it will be either a breech or a shoulder. Again, let me show it to you over here. So this is your normal presentation, which is the head, the cephalic presentation coming down nicely. Over here, you saw that because it was an abnormal lie, it was transverse, and when the contraction came, the shoulder presented, which cannot be delivered, and you have to do a cesarean section in this case. This is showing the full extension of the head. It should have been like this, but it is like this, extended. So that would either lead to a brow presenting or a face presenting. And this you can see is a breech. And this is the most naughtiest one. It's sticking its foot out. Okay, so we call it a footling breech. And again, this cannot be delivered. And this one just loves hugging its own legs. So it is in this strange position in which we call it a frank breech, where it lifts up its legs and hugs them like that. Okay, so these are the different presentations of breech presentation. Now, to add something else which you would want to know, and you have heard about it, is about denominators. Okay, we talk about occipital anterior, occipital posterior, and these positions. I will come to that, first I want you to be confident in understanding that whatever is presenting in labor, every presentation has a denominator. It's just a fancy word of saying that we will choose which part on the presenting part we want to describe the position of the baby. Okay, so in the head, we choose to talk about the occiput. So the occiput in a cephalic presentation, our occiput becomes a denominator. Okay, and if it's a breech presentation, then the sacrum becomes the denominator. We have to talk about which way the sacrum of the baby is facing. Just concentrate on these 3 points and don't get confused with the other things. If you can just remember that and understand that, that's a big step. Okay. So with the head presenting, we will talk about the occiput. With the breech presenting, we will talk about which way the sacrum is. And if the face is trying to come out, the pelvic outlet, we will talk about the chin, which is called the mentum, as the denominator. Okay, so here we go. Now, as I told you, whenever you want to choose the right and left, you have to talk from the mother's point of view, because we are delivering the baby for the mother. So now this is a cephalic presentation and the occiput is on the right side of the mother. So we are going to call it the right occipito-anterior position. When the fontanelle is more towards anterior part, then you would call it anterior. And when it is absolutely transverse, you will call it is right occipito, but more towards more right, then it will be right occipito transverse. And if the occiput is absolutely facing the back of the mother, we will call it a right occipito posterior position. Okay. Any questions so far about this? And I'm happy to go through it again.
No questions in the chat box either, so they have understood.
I think we're okay for now.
Okay, good. So that's what you would understand. So similarly, if it's the breech presenting, so we would talk about the sacrum and then whether it is anterior or posterior or how it is presenting. I didn't want to go too deep into that because I don't think so you would be required to know the different positions to deliver the baby, but we can always discuss that. So coming to the fourth most important point, and honestly, I think this is less talked about than we talking about contractions, and we are talking about so many other things which are also very important. But if you will not have a mother who was not supported through the 9 months to actually go through this, I would say can be a very scary and overwhelming process. So you would not be able to achieve a normal delivery. Trust me on that one. So we work on a mother's state of fear or confidence in the 9 months, and we help as caregivers to mentally prepare a mother to have a baby. We should help women go through prenatal classes and the partner to attend prenatal classes. So the partner is also prepared to support the mother during labor. Dr. Yasmin will share with me how many times we have had 6.5-foot men falling flat on their heads when their wives are actually coping very well and going through labor. So if you are there to support your partner, you should also know what you would expect. And believe me, all of these are evidence-based points that I'm telling you, that if they are there, then you will see that they are going to prepare the woman and will end up in a normal labor than abnormal labor. A mental health of a woman, and of course, domestic abuse, all these women would end up with more complications in labor than less. Which people are we talking about? Every single person that I'm going to mention now, we have got evidence to say that if that person was there for the patient, then the labor would progress beautifully, and we will have the dilatation as we wanted it to be. So again, I would mention the supportive partner and one-to-one midwifery care. Simply having a midwife there who is well trained and supportive is going to end up in a normal, happy labor than having an absence of midwife. And you can put two doctors in there. Believe me, the result would not be the same until you have one-to-one supportive midwifery care. Of course, you need a competent obstetrician hanging around just in case to identify if there's a problem and need help. Good pain relief, adequate pain relief is also one of the simple things that can help a progress to labor to progress normally. And adequate hydration. This is also associated. Just keep the mother well hydrated. Very simple thing for the cervix, for the hyaluronic acid to change and those effacement to happen. You need water. You need water for a plant to open. We used to say that. So she must be adequately hydrated to achieve that success. So in the end, what we're talking about is a good teamwork, all supporting a mother to have a normal labor.
Doctor, sorry, we just have one question here. Someone asked, what is your advice to patients sternly demanding elective C-section?
Okay, so always we have to ask about the risks and benefits. What I do in my practice is I make the patient tell me what are the risks of a normal delivery and what are the risks of a cesarean section. Unfortunately, because we are getting very good at doing cesarean sections, and I would say unfortunately because our celebrities are also having lots of cesarean sections, people think that it's an easy operation and it's easy for the woman and the baby. It's major surgery, and when you make them sign the consent, you are going to tell them about risks of damage to bladder, bowel, soft tissues, bleeding, and having a scarred uterus, which is a risk of having a cesarean scar ectopic pregnancy in your next labor, and the fact that you would not have many chances of having more babies and keep on having more complications, and also having what we call an abnormally adherent placenta. So now we are seeing the complications of higher order cesarean sections. So it is for us to sit down and have a very detailed discussion. It's not an easy way out.
This is what we discussed yesterday in our lecture about an ectopic pregnancy. And if you remember, guys, I said that any pelvic surgery intervention, you are increasing the chances of damaging your tubes and can lead to blocked tubes, infertility. And also we talked about the scar ectopics. So the patient has to be thoroughly counseled and understands where she's coming from, why she's demanding elective cesarean sections. And as Dr. Sadia said, that they have to be discussed, the complications, risk, and for future pregnancy.
So I just wanted to ask another question myself. Is there anything that, so for example, if you have a cesarean section, is there anything that kind of predisposes for post-operative complications like infection or endometritis? Is there anything that that can predispose to those infections if you have a cesarean section?
First of all, it's just the normal cleanliness of a theater. Of course, it has to be according to international standards, because believe me, if we miss or slip any of the standards of our sterility in terms of the instruments that we use and the theater sterility, that is going to be a big reason for why your patients will end up having cesarean section. And then it is up to the scrubbing techniques. As you would now know, I'm sure you have been through surgical rotations. There is a scrubbing technique which has to be drilled into every doctor, right from being a medical student, which has to be followed. The bigger the surgeon you get, that doesn't mean that your scrubbing technique is going to get less. So you yourself are going to give problems to the patient because your scrubbing technique was bad. So these simple things are the reason for outside reason. And then of course there are the maternal reasons that are going to increase the risk, which is a mother being diabetic, immunocompromised, coronavirus, I have to mention, and and obesity. Obesity always leads to poor healing. And if she has got other immunological conditions, of course, that is going to increase the risk of infection in the mother. And also, if you would perform the cesarean section in more advanced labor, that means full dilatation, and the patient had had multiple examination during labor in trying to deliver the patient, and unfortunately we couldn't, and we end up doing a more cesarean section in more advanced labor, then of course the risk of infection in those would be higher.
Sadia, there's another question from another student. He said, how common is the breech position? I mean, we know the footling type is the most common, but in general, how common is it?
I would say, and you can correct me on that, about 15% or 10 to 15% of patients would be, but that would be for the first pregnancy. If the mother is a multigravida, that means, so to answer for the first pregnancy, it's about 10 to 15%. But if the mother, this is the 5th baby and 6th baby, and unfortunately, she hasn't been good with the gyms and Pilates, and her abdominal, the tone of her abdomen is not very good, and she's had a few babies, then that would be the reason that the next baby would be either any abnormal presentation or abnormal lie because of the laxity of the abdominal wall. So the breech presentation would be higher in higher order pregnancies.
There are no more questions, Sadia.
Yeah, I think that's, if anyone else has any questions, if they want to put them. Oh, sorry, someone's asked a question now. In your career, how have the outcomes changed? So some obs and gynaes say that they see significantly more pathology. Is this true?
There are certain changes that I would like to mention now that you have asked. There was a big trial that happened, the term breech trial. It was around the year 2000 or so. And at that time, having a breech was just a different, as I showed you in the lie, right? It's a longitudinal lie, head end or tail end, and we'll just deliver it. And that's what we used to do. But then we had this very big trial, it was called the term breech trial. And the result of that study was, oh my God, if you're going to have a breech delivery, your baby will end up dying. Now, that was a wrong interpretation of that result, of that trial, and we got to know about that after a few years. But what was very natural and normal for us, oh, it's a breech, and we will deliver it because we are experienced accoucheurs, we are experienced obstetricians, we know how to deliver a breech. That totally changed. And then we just had to do a cesarean section for breeches because, to be honest, you know, our experience of delivering breeches suddenly fell down because everybody was having a cesarean section. So that's a massive change that I have seen over my career, if you have asked the question. And the other one is that I'm sure that you have read about placenta previas, placenta accretas, morbidly adherent placentas. And that's how we grew up learning about them and calling them placenta previas, accretas, and the problems with the placenta. But now we know, maybe over the last 4 or 5 years, that rather than waiting for a 20-week scan or a 25-week scan or a full-term pregnancy, we say, oh, your placenta is in the wrong position. We now know at 5 weeks gestation, with a transvaginal scan, we can predict with high sensitivity and specificity, you have a high chance of having a placenta previa or a placenta accreta. And that is basically the spectrum, which begins with a cesarean scar ectopic pregnancy and is later on a morbidly adherent placenta, which you know as placenta previa or placenta accreta. So that is also the change that we have seen. But regarding complications increasing or decreasing, it absolutely depends upon where you are working. Unfortunately, as I love this quote from Professor Foetal, that still the international community is not waking up to the fact that a woman delivering in the center of Somalia is destined to die in labor, as compared to a woman delivering in the NHS in the UK, which I'm very proud to say has got one of the lowest maternal mortality rates in the whole world. And looking at America, it depends upon where you have the insurance and where you don't have the insurance. Where some areas in America are matching the maternal mortality rates of Somalia because of the lack of care that those women need. So the risk to a mother and baby in obstetrics depends upon where they are delivering. And that's why it's so important, and we are so passionate to teach medical students how well and how important it is to learn obstetrics and gynecology. So that makes a difference.
So
Um,
there's another question.
Yeah, there's the question here. Basically, it's like two stems. So it says, what about twin pregnancy? Can the delivery be vaginal or does it have to be C-section? And then a question following this is, and what if the first baby of the twins is in a breech or abnormal position?
Okay, so you've answered your question. Just consider twins. Again, we've been doing this for a very long time. So I'm telling you about my thought process. If the first baby is cephalic, consider this as one baby and you deliver it. And then the other baby, there's so much room after this baby has vacated the uterus. You can just go in and say, come on, young man or young woman, behave yourself. And you do internal version of the baby, get it to one end. As I said, for us, we just need one end, either the top or the tail, and you deliver that. Okay, so I'm simplifying to you a twin pregnancy. So the answer is, if the first twin is cephalic, consider it 2 deliveries at one go and deliver your babies, and they can have a vaginal delivery. Having said that, we recently found out that, I would say, lack of training, lack of support to young doctors, we found that there were lots of complications in delivering twins vaginally. And the Royal College of the UK did a lot of research to say, shall we stop delivering twins? Shall we stop them and doing cesarean sections of all the twins? And I'm so glad that they didn't advise that. And they said, go back to your teaching and training. There's a way to deliver twins. But of course, if the first twin is not cephalic, then it's no point taking the risk. Then I would advise to do a cesarean section if the first twin is not a nice longitudinal line and cephalic presentation.
There's one more question.
Just add on this one, is exactly the same thing that after the HANA trial, which was the Canadian trial you talked about, when people stopped delivering breeches, and the skill of breech delivery gone. Me and you, we were trained in, the time when we can do all sorts of deliveries, whether breech or Keelan's or all that. But the thing is that skill has gone. And similarly, thanks God, the Royal College didn't sort of agree on twins delivering by cesarean section, because that skill will also go. So it's important for the students who are trying to pursue their careers in obs and gynae that they try to sort of get more into getting all sorts of experience. Because I know these days is more emphasis on the time and, getting that's 8 hours and go. But if you don't do these things practically, personally yourself, you will never get the experience. So it's all about obstetric is hands-on.
Okay, there's one more question. I think we'll probably just make this last one and then we can move on to the CTG lecture. Basically, someone asked, can a patient have a vaginal birth if she had a previous C-section, and is it safe?
Yes, absolutely. In our hospital, when you have a good teaching hospital and you know how to follow the red flags in which we would stop somebody from having a delivery, then you can give them, like in our hospital, we give them 75 to 80% chance of having a nice normal delivery after a cesarean section. And that is called a vaginal birth after cesarean, a VBAC. So that's why you will learn about the CTGs, okay, because the risk that you have in labor is that, is the scar holding on? Is the scar going to rupture during the labor? That is the risk that you have whenever a woman with a previous cesarean section is delivering again. So there are lots of telltale signs that we learn how to find out so that we are quick to do a cesarean section during labor if we are worried that there is any concern with the scar opening up. So that's one of the reasons that we would do a cesarean section. And then you have to look very closely in the antenatal period as to why did she have a cesarean section in the first place. So if it was a bony abnormality, if it was something to do with the soft tissues of the patient, which hasn't changed, then it's no point making her go through a labor again when you're sure that that change hasn't gone. So that's how you would do a good assessment in the 9 months, what we call a risk assessment, and then offer your expert advice to say, yes, madam, you can surely try to have a vaginal birth after cesarean section, and you have a 75 to 85% chance of having a nice normal delivery. And if there is problem during labor, we are experts in both looking at CTGs, and we will be able to tell you that we should stop the labor and do an emergency cesarean section.
Okay, I think that.
Yeah. 5 minutes.
So yeah, I think 5-minute break should be fine, and then if you want to continue with the CTG lecture after.
Okay.
So we'll, if everyone watching just wants to take a little break, and then we'll start again in like 5 minutes or so, and we'll talk about CTGs then.
Great. Okay. Thank you. Thank you. See you soon. Thank you. Okay, are we good to start, Irish?
Yeah, I think we can start now. There's still quite a few people here, so I think you can go ahead and start now.
Okay. So now we're going to talk about CTG, cardiotocography, and there's been lots of questions about it. So I'll try to explain it slowly, and that's why I've got my favorite mode of explanation, which is a pen and paper, which I still think in the 21st century, I still enjoy teaching with that. So why do we do CTGs? So if we have a normal CTG, it is associated with a very less probability of fetal compromise. So we can reassure the mother that your baby is fine if we have a CTG. And that's why we developed CTGs, to find out whether we have a compromised baby or not. It kind of looks like that, lots and lots of squiggly lines, okay? We'll try to make sense out of them. The top part is the baby, okay? And the bottom part is the contractions. Is the uterus contracting when so we have the baby here, and the lower part is telling us, is the mom contracting? So top part, baby's heart rate, and bottom part is the contraction of the mother. Now remember, people think that the most important part in the CTG is to look at the fetal heart rate. I would say to you, the most important part to look first is the contractions, because that is going to give you the difference. If the mother is not in labor and the CTG is compromised, you would be more worried, because when a mother is in labor and she's contracting, we do expect a bit of fetal compromise, and we are going from point A to point B, which is from zero dilatation to full dilatation to having a baby. The process is on, and the baby, we will look at it differently. But if the mother is not contracting, we call it an antenatal CTG. The cervix is not effaced, not dilated, baby is not ready to come, and the CTG is abnormal. That is the most dangerous time, and you have to decide, first of all, what is upsetting the baby and what are you going to do next. So my advice always, till now, senior doctors make this mistake. They comment on the CTG without knowing whether the mother is contracting or not. So that is the most important part in the CTG. Now, whenever you want to remember the CTG and all the different things in it, we have got this very good mnemonic, which is Dr. C. Bravado. So let us start with that. So that's how you would write it, Dr. C. Doctor means define the risks. Now, one thing I want you all to remember going away from this lecture is, nobody, this is how I say, nobody in this world should be on a CTG. No mother should be on a CTG, because she should be low risk. Yes? If there's a nice normal pregnancy with no risk, no blood pressures, no diabetes, no obesity, everything is fine, no bleeding, then the mother is low risk. And a low risk mother doesn't need a CTG. So whenever you want to say, what risks am I defining? Then you have to go up as medical students, especially when you see a woman in labor and she's on a CTG. I want you all to go and say, why is she on the CTG? And that is your answer about defined risks. Okay. So why was it that initially she was on a CTG? That is the risk. So now you are going to look at her in that perspective. Oh, because she's got blood pressure. Oh, because she's bleeding. Oh, she's diabetic. Oh, she's got a small baby. That's why she's on a CTG. So this is the meaning of defined risks. The C in Dr. C. Bravado comes as contractions. As I explained to you, we need to know when this mother is on the CTG, is she in labor or is she not in labor? Yes, and that will immediately alert you whether it is an emergency or not, and why is the baby not happy even when the mother is not in labor. So the first thing that Dr. C. Bravado mnemonic also makes you see is the contractions. So you will say, no, she isn't, or yes, she is, and she is contracting 2 to 3 times every minute. Okay, so now you have identified the most important part in a CTG. Now, Dr. C. Bravado, baseline rate, A for acceleration and D for deceleration. Baseline rate, you have to define the baseline rate. You have to tell me whether there are accelerations in this CTG or whether there are decelerations. Now, what are they? It is made up of, let me do it again. So we are defining baseline rate, accelerations, and decelerations. Let's look at a CTG. It is made up of, this is the heart rate of the baby. And we go up to 200. In some cases, babies have got heart rates more than 200, but it kind of goes up to 200. So this is the heart rate of the baby. And this is the time where one large box is equals to 1 minute, 3 large boxes equal to 3 minutes, so on and so forth. So the first thing to identify in Dr. C. Bravado is the BR, which is the baseline rate. So the first thing you want to find out is, what is the baseline rate, heart rate of this baby? Anybody wants to tell me what is the heart rate of a baby?
They can't.
Sorry?
Is it normally 120 to 180?
120 to 180. Any other takers? Any other number? This number is very important. So one thing you want to remember is the heart rate of the baby. Wake up in the morning and say, what is the normal heart rate of the baby? 110 to 160. So this number is what you have to remember, right? 110 to 160, 110 to 160. Because these are guidelines and we are British trained, so we follow the NICE guidelines, and this is how we would describe it, okay? So you will look on your chart, and anywhere between 110 to 160, let's say this heart rate is 120. Are you happy? Yes, because we have said anywhere between 110 and 160, we are happy. So this is your rate. Baseline rate should be between 110 to 160, anywhere here. So what is variability? The next one, Bravado, is the variability. What is the variability? Now you will see that the fetal heart is never like a straight line, okay? It is like a squiggly line, and we call this variability. So you will define it as the movement of the fetal heart rate about the baseline. And that's how you will remember that's variability. So these squiggly lines up and down the baseline is the variability. And it moves up from 5 beats to 25 beats per minute. So the variability is allowed to be as small as 5 and as large as 25 beats per minute also. So this is the movement of the fetal heart rate about the baseline, is variability. Then what is accelerations? So movement of the fetal heart rate above the baseline is an acceleration. Okay, let's be very clear with these terms and then we will describe further as to what they are. So movement of the fetal heart rate about the baseline is variability. Movement of the fetal heart rate above the baseline. So you told me that the baseline was 120 here. So if it goes up to 160, any upward movement, like an acceleration. Then movement of the fetal heart rate below the baseline is a deceleration. Okay, so the baby is merrily going and then suddenly the heart rate drops and then it picks up. So you will find in your CTG some accelerations like that, and then you will find some decelerations like that. Okay, so your Dr. C. Bravado helps you to remember a baseline rate, accelerations, variability, and decelerations. Okay, I would also give you an analogy of the CTG in terms of swimming. Okay, so imagine the baby as a swimmer, And it's merrily swimming, and it's swimming, and it's going from point A to B, really wanting to see its mama, and it's got strength, and it's got good oxygenation, its placenta is very good, and it is happily going. And then it just thinks about, oh my God, I'm going to come out and see my mama. It's happy, it does a nice acceleration, then comes back to baseline. It moves about its legs, hands, arms, happy baby, right? So you will see happiness by continuously seeing the baby with a little bit of accelerations like that. So that just makes a happy CTG. Then something happens to this baby. Something terrible happens. It gets kicked in the stomach for some reason, domestic violence, abuse. The placenta shears off. And the happiness in the labor is now going to get bad. And the oxygenation of the baby is going to go down. So the baby is going to start to conserve itself. So swimming, and then suddenly its oxygenation is going down. So its heart rate goes down. But then many physiological changes take place, and it kind of comes up. I say, no, I must keep going. I must keep going. Then it starts to really conserve itself. And the happy variability that you saw here gets less and less and less. So even when it comes down, this line becomes really a straight line. And I told you that the normal variability has to be about 5 beats minimum. So if its heart rate was 120, it must go up and down about 5 beats. Is it doing that? No. Now it's just a straight line. So the variability is abnormal here. There are abnormal decelerations. And every time the baby wants to carry on, its heart goes down again. So you don't really have to be a senior obstetrician and know all your obstetrics to tell me that this is a happy baby and this is a sad baby. So that is the most simple thing that I want you to know about a CTG. Okay, we don't like decelerations, we love accelerations, and we like a bit of variability. Okay, and that is how you will remember your Dr. C bravado, which so you will never forget what you have to look in these squiggly lines. Okay, so you've defined the rate, Dr. C for contractions, BR for baseline rate, accelerations, variability. Dr. C bravado. For O, they say overall. And I always say that overall means that you started the CTG for some reason, and then you saw this happy trace and you say, oh, overall, I'm happy, everything is going fine. And you end up seeing this trace and you say, oh my God, I'm not happy overall at all, and I need to make a plan. So that's where the O comes on, that you can't just do a CTG and then say, oh, well, you have to have a plan, a comment, a management after doing the CTG. Okay, so that's a simple way of describing it. Now, I'm sorry, it's a busy slide, but I will do it over here so we can remember all these numbers, and we'll do them slowly. Now, this is a nice guideline. As I said, this is the UK guideline of helping us to know what I call the red, amber, and green situation. Or I should say green, amber, and red situation, right? So all these numbers tell you that we are okay, or we are going towards an amber situation, or we are going towards the red situation. So reassuring means green. Everything is fine. Our baseline rate, the risk would be minimum. For some reason, we put the patient on the CTG. Maybe she had a headache, or she was complaining of contractions, and you want to know whether, and she had a bit of blood pressure, so you put it there. And then you look at the rate. So if your rate is between 110 to 160, you're not worried at all, and you're going to say, that's a normal rate. And then you suddenly note that your 160, it's creeping up. This baseline that you identified to be as 160 is now actually 170. That's a bit high heart rate for a baby, but it is still less than 180. But that doesn't mean that you will now be happy. You're in the amber area. So you are going to think about, what is upsetting this baby that is making its heart rate go higher? Similarly, when your variability, which was the movement of the fetal heart rate about the baseline, so it goes up to 5 and can go down to 5, but keeps moving up and down. If it goes up to 25, that means if I would say that the baseline rate was 120 and your movement up and down is up to 125, you're happy with that. But if it is doing too many oscillations of more than 125 now, you will start getting a bit concerned. That brings you in the amber direction. Now we come to the decelerations. Now you will find many confusing things about the deceleration. Try to keep it simple, okay? And just say, as I said, I think I like the swimming analogy. To explain to you the relationship of the decelerations with the contractions, okay? So the mom is contracting. Remember, this is the most important part of the CTG, the contraction part, okay? So the mom is contracting. What happens when there is a contraction? As you know, that the blood flow to the uterus is slightly decreased. That's why the Americans call labor as a stress test, right? When you stress the baby with a contraction, but the baby is nice and healthy and it can take a bit of a squeezing for it to come down, you will see that there are no problems with the CTG, okay? So even when the mother is having a contraction, there are good accelerations along with the CTG. So baby is not upset, okay? But sometimes you will see that as you squeeze the baby with a contraction, which reduces the blood supply to the uterus, the baby goes a bit ow, 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 and heart rate goes down. And it says, no, I'm okay, I'm fine, I'm fine, I'm fine. And then you get a nice acceleration again, only to wait for the next contraction and it goes, oh, ow, 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 ow. And then it comes back to a nice, happy baby again, okay? So we call them early decelerations, which are acceptable and kind of tells us the normal physiology, okay? So you will see that the trough, the peak, I would say the peak of the contraction matches exactly to the trough of the deceleration. So these are early decelerations and we are all happy about it, okay? Then we start seeing another pattern and we start thinking, are we still happy about it? So you keep on having contractions. The mother has a contraction here, then she has a contraction here. You're allowed to have about 3 to 4 contractions in 1 minute, okay? We note that the baby's heart rate goes down, and even when the contraction has come down, there is no stress. Even when the contraction has gone, the heart rate is still down. So the baby hasn't got enough, shall we say, reserve to combat with that squeeze that it got with the contraction. So it's just like still, ow, 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 I need to get my heart rate back up again. So you will see that the peak of the contraction is not matching with the trough of the decelerations. They're a bit late. And that's when we start getting worried about this baby. Okay, we are saying, why isn't it picking itself very quickly? Is it getting tired with the stress of the labor? So we don't like these. We call them late decelerations. So this is the easy part. Any questions so far?
No, there's no questions in the chat box, so I think you're okay to continue.
Okay. So this was the easy part. I'll just repeat it again. You understand the contractions. The CTG is picking up the contractions. We have a contraction on its peak. You get a deceleration, but then the baby is happy with it. and then it carries on, and then maybe there's a deceleration with that contraction, and then it carries on. If that is not the case, they are not matching, then you start getting worried because the baby's heart rate goes down more than the peak of the contraction. So these are late. So this it is easy for you to pick these kind of contractions. But then, as you will see in the slide, now they are talking about variable decelerations. And now they are talking about concerning characteristics. Okay, what is that? Variable means when you can't really time it, as I've been describing, a perfect deceleration with a perfect contraction. When you are saying, okay, the contractions are here and there, and the decelerations are happening in a variable manner, when you cannot really match it to the contractions. So then what they want you to do is, they want you to look very carefully on these squiggly lines now. They want you to look very, very carefully and say, are you concerned in the way this baby's heart rate is dipping? Are you concerned about the variable decelerations that is happening with the contractions? So if you can't time them, then you have to look at the shape of the variable decelerations. And the more they have strange shapes, the more you start getting worried. And then remember the swimming baby analogy, it will help you. So let's start. So we have a baby whose heart rate goes down, and then it quickly picks up and says, no, I'm fine, mommy, I'm fine. I had a decel, but I'm okay. And it keeps happening. So you're not too worried about it. It went down quickly, it came back, and then it really said, okay, I'm good, and it carries on, okay? So you're not really concerned about these kind of decelerations, even if they're quick to come, and then they happen, and then they go away, right? So you're not really worried about, so they don't have any concerning characteristics. Which is the deceleration that now you are going to worry about? So your swimmer baby goes down and it says, oh my God, I need to pick myself up. Okay. So then it comes back to its baseline again. Okay. So it takes time. So remember that quick rushing back up to the baseline, that's not happening. And what is happening is that it's going to take some time. This is your timeline to come back to the normal. I call it the right tick sign, just to make it easier. So if you get this kind of right tick sign, that's when you would be worried and call that a concerning characteristic. Okay, next one. The baby says, oh my God, I need to come back up. And it goes back up and then says, no, I can't do it again. I really can't do it. I'm tired. And then says, okay, all the physiological factors come, a bit of extra oxygen, move the position. So it will give you, we call this a biphasic sign, or what I like to call it, the W sign, okay? So it's like a little W, or biphasic is the proper word for it. So that's also a concerning characteristic. The poor baby is trying to get up, and then it falls again, and then it comes back up again, okay? So that's your biphasic concerning characteristic, okay? Other really dangerous sign is that it brings, so this was your baseline, 120 or 180, and then it wants to come back, but it never comes back to its baseline. And it just barely continues like that, okay? So it doesn't really reach back to its baseline. Why that would happen. So, so that's another concerning characteristics. So just read more about the concerning characteristics, but these are the three that I want you to remember. But then you have to match them with the contractions. See, it reads, when you will read the guideline, it says that if these late decelerations are happening in over 50% of the contractions for less than 30 minutes with no maternal or fetal clinical risk factors such as vaginal bleeding or significant meconium, which is the baby passing its stools, then you are still in the amber zone. Okay, you are still not that worried because these decelerations are less than 30 minutes. But how long is the 30 minutes? 30 minutes go very quickly. So you can't really go back in your room and say, I'll come back in 30 minutes to check the CTG again, because then you will see that these decelerations are actually persisting. And as soon as you put them into more than 50% of the contractions, and the concerning characteristics, your right ticks, your W's, you're not reaching the baseline is also increasing, you would say, look, I'm going to put this in the red zone, which is the abnormal zone. So the heart rate is increasing. You were sitting happy at 110, 160. Then you started noting it to be either below 100, and between 100 to 109 is the middle ground, and then below 100 will be abnormal, and above 180 would also be abnormal. So concentrate on these numbers and understand that we have got very, very strict criteria in calling them reassuring, green zone, no problem, non-reassuring, hang on, something going on, so exactly 100 to 109, and then the abnormal at the abnormal zone. Okay. Regarding accelerations, as we discussed, that is the movement of the baseline or movement of the fetal heart rate above the baseline. There is a very strict criteria for acceleration. Okay, if you have accelerations, even with a reduced baseline variability, remember less than 5, the baby is happy. Right? Remember your swimming baby moving its leg, giving you these nice accelerations. Don't worry about it so much. So they say that if the absence of accelerations, that means you just have a little line with none of this and just a straight line. Again, the absence of acceleration on an otherwise normal CTG also does not indicate fetal acidosis. So you have your other features with no decelerations and a good variability. You can wait on that baby. And sometimes we know how to wake babies up. We go and tickle its head, give the mom some cold water, change the mom's position, and the baby then moves around, and then we can get an acceleration. So we have got tricks to do that. Okay, now again, this chart can be a bit complicated, but take a deep breath. Remember again, the green, amber, and red zone. We discussed, what did we discuss? We discussed all our Dr. C bravado, baseline rate, acceleration, variability, okay? We know the normal parameters. Our baseline rate is between 110 and 160. Our variability, which is the movement of the fetal heart rate about the baseline, is between 5 and 25. Our accelerations, yes, we've got a baby, lovely baby moving around happily, showing us the acceleration, which is the movement of the fetal heart rate above the baseline. We're happy. And decelerations, we don't have any decelerations, or maybe there's just one quick one which goes down and comes back up again. So we're all happy. We have a normal CTG. Then we come to the suspicious one. Okay, suspicious one is, I have got one feature which is non-reassuring. Non-reassuring feature is something which is not normal. So remember, we go back to our numbers here. This one was a non-reassuring features. Baseline rate between 100 to 109 or between 161 to 180. Our variability is just less than 5 beats for 30 to 50 minutes, or more than 25 beats for 15 to 25 minutes. We have got some variable decelerations, but no concerning characteristics. What were those concerning characteristics? The little white, the tick, right tick, the W, the not reaching the baseline again. Okay, so we don't have any of those. So we'll keep it in the amber because it's still having some decelerations, but we'll keep it in the amber. Or we have got some concerning characteristics. Yes, there is a right tick and there is a W, but only less than 50% of the contractions or not more. Or if we see, oh, we're seeing some late decelerations, but they are still less than 30 minutes. So we'll keep it in the amber. So all of these are our non-reassuring features. So you pick all those non-reassuring features, and if you get 2 of them, yes, you make it into a suspicious CTG. And if you have one abnormal feature, just one, your heart rate goes down below 100, or it goes above 180, your variability is less than 5 or more than 25 for more than 50 minutes, or you have got variable decelerations with all those concerning characteristics for over 50% of the contractions for 30 minutes, or you have late decelerations for 30 minutes, or forget about everything. The baby's heart rate went down for more than 3 minutes. The 3 boxes on the CTG, that's it, that's the bradycardia or prolonged deceleration. That's pretty abnormal, right? So you are going to pull the buzzer and say, look, I've got 1 abnormal features or 2 non-reassuring features. This is a pathological CTG. I need to do something. And there are only 2 things that you can do in a pathological CTG. Always remember, once you have classified it, now you're an expert, you know your Dr. C bravado, you know your definition, you know your green, amber, and red boxes, you know the features, you put it there and say, oh my God, that's a pathological CTG. Only 2 things you can do in a pathological CTG. You get it better by changing the position of the woman. You can give her some fluids, you turn her around, and these are called like certain measures that we do, and it should get better. Better means it should become normal. If it doesn't get normal, you have to go and do a fetal blood sample. That means you have to go with a special instrument, reach to the I can get Bob the way to help me. You reach through at least a 5 centimeter dilated cervix. You can scratch the baby's head, take a little sample, just like the diabetics. They check their blood sugar. You can check the oxygenation level on the vertex of the baby, and tell the mother that despite the CTG, the decelerations, the baby's fine. Don't worry. And if you cannot do that, please deliver this baby with an emergency cesarean section with a pathological CTG. Okay, let's go for the questions now. I'm happy to repeat any of that. I just kept it nice and short so we can actually answer questions around whatever you want.
So if anyone has any questions, they can put them in the chat box or just say them out loud. There is one question here. I think you did kind of touch on it, but someone asked, is there an automatic alarm for an abnormal CTG?
The posh new ones have got alarms for the heart rate of the mother and for decelerations. And now that you ask, I will tell you the best alarm that we have is that sometimes when we have got a pulse oximeter on the mother's pulse, in the good CTG machines, you will get 3 things. So you get the contraction, you'll get the CTG of the baby, and you will see there is a thin line, and that is the maternal pulse. So when sometimes you are not monitoring the baby correctly, you will see that the fetal heart rate merges with the mother's pulse, and that's what makes the machine go crazy, because the machine cannot have 2 lines mixing. So either you're not monitoring the baby, and unfortunately I can tell you many cases when we were actually putting the CTG on dead babies, and the line that we had was actually the mother's pulse, giving us a nice squiggly line. And that's why this feature was built into the CTG to tell us, hang on, something is not right because the lines are mixing and you might not have got the baby. So that's when it alarms. But the best alarm is your one-to-one midwife who's sitting there watching that CTG like a hawk and calling you every 2 minutes saying, Dr. Malick, I'm not happy with that CTG. There are too many decelerations. There are more than 30 minutes now. There are more concerning characteristics on that trace. And so that's your best alarm, a good midwife.
There's another question here saying, can you please show how you measure the fetal markers if it is pathological?
We measure the
fetal markers if it is pathological.
Can you rephrase it? We are saying again the numbers we are talking about, right?
No, sorry, I meant just, on the head, to measure the diabetes and when you mentioned on the baby's head, just how is that done? Like, is it?
Oh, okay. I'm sorry, I should have put a photograph of that one, but you can YouTube it. Basically, the cervix is dilated, right? About if you have even 5 centimeters dilatation, you can feel the head. You're doing a vaginal examination and you're feeling the head. The head is there. And I know it sounds gross, but it's a scientific surgical procedure in which we put a telescope-like instrument into the vagina and touch the baby's head. And that is the time when, just to make the mother feel better, because a poor girl, she's going through this uncomfortable procedure of a doctor putting an instrument into her vagina, reaching to her baby's undelivered, half dilated cervix. It's uncomfortable for her. So you keep chatting with her and tell her the color of the hair of the baby. If there's not much hair on the baby, you shouldn't tell that. It's not but if the color, you can give some information about the scalp. Then you are going to put some Vaseline on the baby's head. And that would make the blood drop into a nice drop, and you actually scratch the head. It doesn't hurt them. So tiny, tiny scratch. And then you take the blood into a little pipette and it comes out, and you put it in your machine, which is the arterial blood gas machine. And that machine tells you about the oxygenation of the baby. Exactly like these numbers that we are very strict for you to tell us 110 to 160, we have got very clear numbers for oxygenation levels of the baby that must be within the normal parameters. If they are not, stop the labor, deliver by emergency cesarean section. If they are normal, we carry on the CTG, we carry on with the labor. And if the CTG remains pathological after 30 minutes, you have to repeat the same process of taking the blood gas again. Does that answer that?
Yeah.
Okay.
If you go through anything, I can describe anything again, please, because I know this can be a bit difficult. So let me know if there's anything I can. Dr. C. Bravado, everybody happy with that?
Yeah, there's another question someone's asked. Can a CTG be done anytime during the pregnancy?
Yes, when a woman is not in labor, so two types, when a woman is in labor and when she is not in labor. When she is not in labor, then just to reassure the woman, sometimes we just do a CTG. If we are concerned that the size of the baby is small or she's not feeling the movements of the baby, that is when the CTGs are really, really reassuring. And we tell the woman that, look, we've done a CTG, it's got accelerations, no decelerations, good variability, and the baby is fine. So that's when we will do it before labor. And then if the woman is in labor and you have identified her to be high risk, remember, define the risks. Don't do a CTG if she's low risk. You will just listen into the baby after every contraction. And if the heart rate is between 110 to 160, just by listening in, you don't need to do a CTG. So if you have a risk, whatever is worrying you for the mother or for the baby, then you will do the CTG during labor. So before labor and after and during labor.
There's another question here saying, what do you think of self-monitoring of pregnant by CTG with devices for home use?
That was started by Tom Cruise, is my information. Absolutely wrong. Okay. Never do that. There is no information out there for a woman to monitor her own baby with any gadgets that are out there. A good midwife without any gadgets is good enough to reassure a woman just by measuring her tummy, making sure that the fetal movements are good, and 2 or 3 scans during any pregnancy is enough for you to reassure you that everything is fine. If you're a healthy lady with no problems and your midwife is happy with you and your doctor is happy with you, then even if honestly you sit there and you monitor your baby for 9 months, if there is a problem, you will not be able to pick that problem in this intense monitoring. So that's strongly not advised.
So, Dr. Malick, thank you very much for your lectures and for your time. My question is, in which case CTG could give a false positive result? So it can, usually at the beginning you say that it's better if you don't do a CTG, if a woman doesn't do a CTG, because that's not a good sign to, to be an examination to assess if it's the so you say this, but I wanted to make clear in which case it should be supported by an echography, in this case the CTG, and also can the result depend from the operator which is reading the paper and the result of the curve? Because sometimes it could be, misleading. In this case, it can be misread. What do you think?
That's a very good question. I'll try to break it down and answer it, and please tell me if I've covered all the things that you're asking. So first of all, the sensitivity and the specificity of a normal CTG is close to 100. Okay. So if you are getting this CTG, all right, this baby is fine. Until and unless what I've just mentioned to you, as you also mentioned, the operator problem. This was a dead baby, and we were picking up the maternal pulse, and it's such a sensitive CTG that even a little bit of respiratory changes in the mother's pulse, it is picking up and giving us a beautiful trace all night long when we were monitoring a dead baby. Okay, so if that is not the case, and now with our new machines, we are very good in that, and that has reduced over the years that I've been working with the CTG. So if that is not the case, which is really, really rare, and because you asked the question, I answered that. If you have this trace, you have a close to 100% sensitivity or specificity that this baby is fine. Okay. If you have this trace, all right, anybody happy? Just by drawing this, my heart rate goes up. I'm just drawing it. There's no baby attached to it. My heart rate goes up when I draw this kind of CTGs. Anybody happy? You want this baby delivered. Either vaginally, put a forceps, get it out, do a section. Can't be having this baby who's just going deep in the water, coming up and saying help, and then goes down again, right? So, but you know what? We do a cesarean section, we do a difficult forceps, baby comes out fine, and the gases were also fine. And don't ask me to describe how did that happen. Some babies have got amazing reserve. So they are keeping themselves good, and you deliver them and they're absolutely fine. So over here, that you can say that this is not 100%. Okay. Then you talk about the person reading it. Doing what we do all night, and in terms of looking at CTGs, and this small writing that you are also looking at it, and you say, okay, for your exam, you are going to read it. I am responsible for looking at least 14 to 15 patients per night in 14 different rooms, looking at little squiggly lines going like this and maybe like this, or was that a right tick, in 14 different patients. So do you think I can get it wrong? Yes, I can get it wrong because I get tired. So we look at it and say, oh, that's fine. But if you show me the same CTG 2 days later when I've had my breakfast, I've had my sleep, and I look at it and say, How did I sign that CTG to say it was normal? I was tired and I did a mistake. So to avoid that, we have come up as obstetricians and midwives an amazing phenomena, and we call it fresh eyes. So much so, I know it looks creepy, but we have got little stickers on our CTGs with these fresh eyes, which means that you have the same midwife looking after the patient for 10 hours and she's not delivering. Remember the graph? She's not getting from A to B. She's still 3 centimeters. You're pushing oxytocin drip to get her there. And she's watching the CTG and she says, oh, it's fine. But we have this phenomena now in our labor ward where it is called fresh eyes. That every 3 to 4 hours, somebody else from some other room, or maybe their patient has delivered now and they don't have they will come and they will put the fresh eye sticker on the CTG and would come and look at it and say, fresh eyes done. Yes, you're right. It is a normal CTG. Let's carry on. And these decelerations have got non-concerning characteristics. You shouldn't worry about it. Let's give this lady a chance to labor. So this is how we get rid of this inter-observer differences so that we don't risk a baby because of human factors. Because we have to talk about the human factor in all this interpretation that we are talking about.
Thank you very much.
I'm sorry about my voice. I'm slowly losing my voice. I think I got some infection yesterday.
That's fine. I don't think there's any questions at the moment. If anyone else has any, they can say them out. But I just want to say thank you so much for taking your time to teach us all and teach us about labour and CTGs. Obviously, with the current pandemic, we're not really being taught by our university, so this is helping give us like a good clinical approach and clinical outreach for all of this. So again, just thank you so much.
It's my pleasure, absolutely my pleasure. And we can always do recap sessions. You can collect your questions and things. We'll send you our emails and you can send your questions and we can always go through it, what we didn't cover, or you have further questions at some point.
That's great, thank you. And we are recording this lecture as well, so I'll send that to the students, and then if you could, I'll send you my email address. So if you could email me the slides as well, I'll make sure to get that to the students as well.
Good job. Well done to you also for arranging this. I think it's a really good effort.
No, that's fine. But thank you for everyone as well who attended. And I think we'll be doing one as well on Sunday. A gynaecologist from Manchester, St. Mary's, will be giving a talk on miscarriages and abortions. So if people want to tune in for that, I'll send the link then. But yeah, again, thank you so much for taking your time. And then if there's anything you'd like to teach us next week as well, I'm sure we'll be more than happy to attend that as well.
Yeah, I've got a good week next week, so same time is good in the evening. We can discuss, you can ask participants what they would like as a topic. I'm happy to talk about any of the topic that you guys choose. That will be better.
Yeah, that's fine. Okay.
Thank you. Thank you for your attention. Thank you. Been a good group. Thank you. Okay.
Thank you for your time and take care.